The Engaging Physicians Project. The title is sort of a misnomer. We've had a real challenging time in engaging physicians in the interior health region. At first it was a source of frustration for me. Now it's kind of an intriguing challenge. It's a community-based project, and the main goals were to educate and inform general practitioners in the Thompson, Okanagan, Shuswap, Kootenay areas on creating a non-judgmental and welcoming clinical environment for gay, bisexual men and men who have sex with men, and to help them to allow for safe disclosure of their sexual practices and health concerns. This is an interesting collection of statistics that came out of a Living Positive survey a few years ago. I think it was 2004, through a website. And you'll have to read from the top down to the percentages, but you'll see the difference between identity in private as opposed to public. And the most noticeable is you'll see under straight, in private, 16.7%, in public, 62.5%, then gay, 49% in private, and then correspondingly 26% in public. So there's obviously a percentage of men that are engaging in same-sex activity. And to give you an idea of the size of the area, this is the Interior Health Authority region. So it's huge. And to communicate and to get people together in that area, it's a huge challenge. So the first goal was to increase the number of general practitioners within the interior health that reported increased awareness, knowledge and understanding of the health needs of gay and bisexual men. The second goal was to increase educational resources available for GPs and other healthcare practitioners. And the third goal was to engage a number of local students brought in by participating academics. Over the 2 years of the project, we've had a nursing student from Selkirk who did some wonderful things for us, and I've listed them on the slide. And we've also had the opportunity of having some students from UBCO who again gave us some wonderful work designing and refining a consultation tool for physicians and sending it out. And as you can see, we sent out 655, and we had 113 responding, which was 18%. And I do have a handout if you're interested at the end. If you want, you can have that, which will show the raw data. This year, we've contacted medical clinics in Kelowna and 2 in West Kelowna and made appointments with medical office assistants and managers. As you can see, we've given up with talking directly to physicians. So we thought, who else is an authority in the medical clinics? And of course, we thought, obviously, of the medical office assistants. And we did meet with some success and obtained an opportunity to meet and discuss the project with 10 out of the 12 clinics. And we had an artist render a picture to be included in a more office-friendly poster. We have a previous poster which was done last year, and while I think it's fine and wonderful, the feedback from the students was maybe to give them an option of a different poster. So we'll be offering 2. Just to see which one gets picked up. And the other part of it is designing a professional development workshop. And we're in the process of putting that together, along with the physician dialogue and consultation. The medical rounds, we were almost there a few months ago, I thought. But the problem in the Interior Health Authority is that it's very decentralized. And so to be able to organize it so that you would have simultaneous visits to the different hospitals, it was nearly impossible because there were different people at each hospital in each different area within the Interior Health Authority. So while I had one booking in Nelson, I couldn't get the others on board at approximately the same time. And this was important because we've had, I believe it's in Vancouver here, Dr. Trevor Corneal, who volunteered to come up and speak at the rounds. So to be cost effective around time and money, it would have to be, very tightly scheduled. We've gone to some outside resources for the toolkit, one of which was Fenway Health in Boston. Daryle went to the Gay Lesbian Medical Association meeting in Seattle last year and met with the people from Fenway, and they had agreed to give us the use of their materials. So we had to recontextualize it for the Canadian situation, and we've done that and put it into PowerPoints and put them on discs, and we had someone do a voiceover so that it could go into the toolkit and the physician at his convenience could take it out, reference it, and again, thinking about time for the physician. Community resource booklets. We've compiled one for Nelson, Penticton, Kamloops, Vernon, Kelowna, as well as the Similkameen. And within each booklet, there are Google Maps, which point to the different offices and resources available where MSM or men who have sex with men might be referred, so that the physician doesn't feel like he's dealing with the client or patient without any backup. We've designed one pamphlet and booklet, one for the physicians and another one for the community. And I have those here too. If you would like to look at them at the end, I can pass them out. After becoming frustrated with trying to discuss things with physicians, and I should add, well, what did I do to approach them? I actually made an appointment and went in and tried to, number one, tell them about the project, invite them to be involved on the advisory committee. I had one physician say to me, I will treat men who have sex with men, but I give all my time to the social gospel mission, and I have a bias. I do not like men who have sex with men. So you can imagine, even though he treats them, you can imagine how that feels going into the office when you're ill. So after having tried to work with physicians, I thought, how can I go the other way? How can I feel like I'm making some sort of progress? So then I thought, well, there's the community end of it. And it was advantageous for me because having moved from Vancouver to a new community, there was the personal work of how to introduce myself to the community and get to know people. So it more or less wasn't worked for me, but at the same time I realized that as I worked at that, I was getting reinforcement back because I was hearing anecdotal stories about, what happened to me when I went to the clinic, or I talked to this physician, or how poorly my partner was treated, etc. So based on a research cafe that Francisco Carrasco held here in Vancouver, we did the same thing in Kelowna, where you invite a few academics some students, some people from the community, some folks who work at Living Positive and other nonprofits. And it was amazingly well attended. It was interesting that the variety of folks, the diversity that showed up, that are otherwise invisible in Kelowna. It was a really rewarding experience. Moving from Vancouver, I was used to having a support group. And I know how valuable that was, and I really missed it in Kelowna. And I think, as was mentioned yesterday, about how important family and social networks, and if you're lacking that, you know, I would say you can live, but you can't thrive. So I started the support group. I've had 5 people come to the support group. While not consistently, I've had 2 who attend consistently, but the word out there is that there are more people who are really isolated, who are afraid to come to the group. Because if they're seen in the group, they're automatically known to the rest in the gay community as being positive, and therefore they feel they won't have any social life. The gay coffee group, which was already going, so I just invited myself, and that's where I picked up an awful lot of information. And then Daryle, through Living Positive Resource Community and the Okanagan Rainbow Coalition, organized a health day at Kelowna Pride, which was amazing. Apparently, while there were people milling in and out during the day, I think it was about 4 o'clock in the afternoon, there was a lineup out the door for the HIV STI testing, which was offered for the first time at the Gay Lesbian Center, GLBTQ Center. This is the initial poster, which I really liked. And I'd appreciate your feedback afterwards if you feel like telling me your opinion. But I really like the sense that it gives, and it was also done by one of our UBCO, Selkirk students, and he's also in the picture, so he actually did this as a class project. And our community partners are listed. And so it's really, really important that we have the participation of all the ASOs in the Interior Health region, because again, going back to that map, it's huge. And I don't think I ever understood when I lived in Vancouver, having grown up in New Brunswick, I couldn't even imagine that kind of distance with mountains and whatever. So,
I just want to,
Daryle.
So just following up on some of the stuff that Kevin said, this project came out of a whole bunch of feedback that we received, or I received in the community, having lived in Kelowna since 1997. And, you know, there's huge amounts of activity happening. I spoke to a guy online who would drive 150 miles to get a blowjob. Our healthcare professionals do not want to talk about men who have sex with men. And the end result of this is we're hoping that we have a toolkit for physicians that can introduce them to the subject, can talk to them about taking an appropriate sexual health history, which most physicians don't. And when we talk about the consultation we did with the physicians, some of the feedback we got, and this is from the Southern Cancer Institute or Cancer Center in Kelowna, they phoned us and told us, after we sent them the questionnaire, they phoned us and told us that they don't treat men who have sex with men. How would they know? Right? So, I mean, it's really, we got one call back from a physician's office that said they were disgusted with the survey, or the questionnaire that we sent them, and take them off their mailing list. So, although we did get 18% of them back, it was still pretty disheartening at the beginning to hear some of the comments that we were getting. It just pointed to the fact of how important this project is. And there is one more thing, and one of the things that we really wanted to have at the end of this is we wanted to have a CME credited course with physicians, for physicians. We have a new medical school starting in Kelowna in 2011. So it would really be nice to have a CME credited course. In Quebec, there is a CME credited course for men who have sex with men that's been around for 20 years. Physicians get CME credit for it. I actually have the course. Bill Ryan sent it to me. It's in French. It's not available electronically, so I'm looking to get it translated because seriously? I don't understand French, so it's on my desk. But I need to find money to get it translated because we really need that in BC. We need to be able to have that type of education for physicians. And we talk about the Interior Health Authority. I think that, you're pretty fortunate here in Vancouver in the West End to have the physicians that you have. But I think if you go across the Port Mann Bridge, I think they're facing the same stigma and discrimination that we face out in the Okanagan. And, I'm a pretty empowered person, and I always have been, so I don't have any issues. But there's a lot of people out there who aren't empowered. And they're totally, their doctors just don't want to talk about it. And I think when we take a look at the bigger context of it, we have to look at physicians taking an appropriate sexual health from everybody they talk to, not just men who have sex with men. So thank you very much.